Everyone deserves to have an endocrinologist to fully understand all of the amazing metabolic processes that our bodies are performing. I'm Dr. Lindsay Van Dyke, and this is the Endo Days. It's Dr. Van Dyke, and this is part 4 of our series, State of the Heart in America. I'm here with my friend and colleague, Dr. John Osborne, a Dallas cardiologist with over 2 decades experience in managing heart disease. In part 1, we examined heart disease in this country, who has it, and how aggressively it can kill. In part 2, we reviewed how we screen for heart disease. In part 3, we learned the standards of care for treating heart disease in the United States and explored some of the controversial methods of treatment as well. In part 4, we want to support you, the patient, so that you can advocate for your own health and avoid your own heart attacks. Remember, early aggressive interventions now will buy us health and longevity later.
First of all, who is better at getting screened, men or women?
Oh, clearly women. There's just absolutely no comparison. I think most men, and I'm painting with a broad paintbrush and being stereotypical, most men act like ostriches, put your head in the sand, don't check your cholesterol, that way it can't hurt you. I'm going to eat what I want to eat because I like eating that. I'm not going to exercise on a regular basis because it's boring. And it's no surprise, frankly, as well published in the literature, that men who are married live longer than men who are not married. And I think the main reason is that they have a woman who's saying, get this stuff done.
Age is the biggest risk factor for anything, especially for heart disease. So primary doctors should be checking cholesterol by what age?
So let me speak to adults, but I'll give you a little insight on the pediatrics, because this is a genetic condition, right? It doesn't just start as we get older, but cholesterol levels, LDL levels tend to go up with age. HDL levels tend to fall. Triglycerides go up with age. Having said that, the recommendations are everybody from the age of 20, as far as adults go, every few years, every 4 to 5 years, should have their cholesterol levels checked, period, across the board. Interestingly, for the pediatric population, it's recommended that every kid between 9 to 11, and again between 18 to 20, has their cholesterol checked, again, independent of risk factors, family history, etc. Because the problem, particularly in younger people, is that they are young, many times cholesterol levels are not checked, and they can have a genetic form of cholesterol, and the cholesterol could be horrible, and yet absolutely no symptoms, and the individuals and the kids and their parents can be completely unaware of it. So it is important that cholesterol is checked periodically, but those are the current recommendations for adults and for kids.
And if the patient has other things going on, diabetes, rheumatoid arthritis, whatever, what do you say?
Oh, absolutely. So these are just general recommendations in the I feel fine, no health problems kind of people. But there are lots of factors that dramatically increase risk. So diabetes, high blood pressure, tobacco use, of course. And you brought up a really great point as well. One of the things that we've begun to appreciate over the last several years is the role of chronic inflammatory conditions and diseases like rheumatoid arthritis, psoriasis, psoriatic arthritis, lupus. Those chronic inflammatory autoimmune conditions definitely do increase the risk of heart disease above and beyond traditional risk factors. So if you have one of those conditions, that these recommendations for screening we'd want to be more aggressive about screening cholesterol in those patients who have those chronic inflammatory conditions as well.
And I would say that in the field of endocrinology, we really recognize just plain old garden variety obesity as being a profoundly pro-inflammatory state, and that has all kinds of negative effects on everything from vasculature to your bones. So how does cardiology think about obesity?
Oh, absolutely. There's no question. It is the great force multiplier for respect to not just heart disease, but everything from fatty liver, sleep apnea, reflux, arthritis.
If a patient has their blood drawn and they check the cholesterol and they're reading the report and it says normal, how do they know they're really okay?
Here's the problem. Half of Americans have heart attacks and die with normal cholesterol levels. So by definition, normal means that's the 50th percentile. It's where 50% of the population is. And so every year, if you look at people who have heart disease, half of them will have heart attacks with normal or below normal cholesterol. So I think that concept of normal cholesterol is really not terribly useful or helpful. And in fact, cholesterol itself, taken by itself, ignoring all these other factors, diabetes, age, family history, but cholesterol by itself is not a great discriminator of who has heart disease and who doesn't, except at the very extremes, people with very low cholesterol, and you can have genetic abnormalities that give you very, very low cholesterol, and yes, they are at a low, very low risk of having heart disease. In fact, if your LDL cholesterol is about 30% lower than everybody else, and there are some genetic conditions that cause that can occur in 2 to 3% of people, their lifetime risk of heart disease is 88% less than the average person. Conversely, if you're unfortunate, you get genetically high cholesterol, and those patients have rates of heart disease versus everybody else that are 20-fold greater than the average person. So cholesterol by itself is hard to figure out whether that's good, bad, or ugly. I think we need to take that collectively. We need to understand family history, smoking, diabetes, high blood pressure, age, all those factors. And frankly, I think one of the great discriminators is get a calcium score. If you got a 0 calcium score, if your LDL's elevated, even if it's above average, you're probably fine. It's not building up. If you have a LDL that's below average and your calcium score is high, then that LDL, that cholesterol level that you have in your body is more than enough and sufficient for you to form plaque.
So earlier in one of the previous episodes, we'd kind of used colonoscopies and colon cancer screening as one of our examples of how to catch cases. And certainly when you have a parent or sibling or somebody who's diagnosed with colon cancer early in life, then you get to start your screening earlier than their diagnosis. So is the same true of first-degree relatives that have had a heart attack or stroke, especially if that was at a young age?
Oh, absolutely. No, I will tell you, there's one little nuance there. Let's say Dad had a heart attack at 50, right? So, and by the way, the number that we usually use is a heart attack, stroke, or a vascular event in a male who's 55 or younger, and in a woman 65 or younger. Okay, that's the number. However, let's just say Dad smoked 3 packs a day and you never did, and Dad was overweight and you're not, and Dad didn't exercise and you did. So certainly lifestyle can play a big role, but having said that, I still think it's useful to think about those age breaks at 55 and 65 for men and women. So if you have a cardiovascular event in a first-degree relative, mom or dad or a sibling, that occurs less than 55 in a male, less than 65 in a female, I think it definitely is a major red flag.
When it's time for treatment, medication is the best way to handle LDL reduction. Just one medication, Crestor or rosuvastatin, is known to drop the bad cholesterol by almost half. So taking that medication as prescribed and keeping up on your refills is so vital. Okay, so let's recap how patients can advocate for themselves.
So, things that you can do. Obviously, the foundation of this preventative pyramid: eat right, exercise. When I say eat right, again, we talked about the role of good diet, avoiding processed foods, increasing amount of fiber, trying to keep the saturated fat low. The Mediterranean diet sort of encompasses all of those. Obviously, avoiding tobacco use, and then regular activity and exercise. I would say at least 30 minutes, hopefully most days of the week, doing something that, as I like to say, get your heart rate up, get you hot and sweaty. How you do that, what the details are behind that, you figure it out. But just be active. That's, of course, the foundation of this pyramid. Another thing I think that we need to do, and now that it's certainly been promoted more rigorously in the guidelines, is ask your doctor, particularly if you have risk factors, family history, etc., or you're just concerned about heart disease, ask about whether you may be appropriate to get a calcium score. I think it's a phenomenal tool that we can use sort of as I like to say, as a pregnancy test, as a binary 0-1 tool. If you have a 0 score, that tells us a great insight about your risk of the next several years of a heart attack. And conversely, if it's positive, that is, if it's not 0, then that alone gives us a deep insight about your risk. And 0 versus non-0, the difference in heart attacks over the next 10 years is 20-fold. There is no other single test, tool, value, cholesterol number that I can check except a calcium score, where I can say if it is normal versus not normal, there's a 20-fold difference in risk. So ask your physician whether a calcium score may be helpful.
I know that sometimes practitioners worry when patients begin asking for all kinds of tests, and it's hard to be your own advocate. So when you are advocating for yourself, be sure that you are reading validated and up-to-date information. And good places to start looking for information is the Mayo Clinic, the National Institutes of Health, the Centers for Disease Control, and the American College of Cardiology. John, do you have anything else to add to that?
I'll only add, because I've been a volunteer for them for a number of years at the national level, is the American Heart Association. They've got a great website that's full of lots of this data. They were also part of the guideline writing organizations. So American Heart Association, they're available at www.heart.org as well.
I want to thank all of our listeners for being with us to analyze the state of the heart in America, and we both hope this has been useful for you and will keep your heart out of the hospital. Dr. Osborn, I appreciate your time and your expertise.
My pleasure. And as I always tell people, why I do this, why I'm passionate about prevention, is my goal is I want you to listen to these podcasts and then go out and use that information to put me out of business.
And as always, you can log on to www.stateoftheheart.com for more information.